All right, so that's kind of depressing information. What I just told you is that we are harming patients with our intubations. Even though the numbers of our first pass successes look very good, and I'll tell you they do. I just ran the 2015 data. We had a first pass success rate overall of, for all comers, cardiac arrest and RSI of around 87%. And our overall success was at 97%. And as you know, we only do 2 attempts at intubation. So by the second attempt, we're at 97% successful. So normally, I would be pretty pleased about that until I started looking at what was happening in the RSIs to the oxygen saturation. So I'm not just going to bum you out with really nasty information that we're hurting people, because I think that wouldn't be fair. None of us got into this business to hurt people. We got into this business so that we could help people. We want to be able to do that, so we need to do this process right. So our solution is DSI. We implemented this on a small scale as part of a PDSA cycle, and we analyzed the results, and I want to share those results with you. We had 5 calls in our early implementation test or pilot phase, and we had no desaturation. So this was an interesting call. This patient was in status seizures, status epilepticus. We gave tons and tons of benzos. I think they probably emptied the truck of benzos. I think literally they ran out of benzodiazepines. Tried to intubate the patient, did a DSI. Were not able to get the patient intubated despite 2 attempts, and then put an i-gel in. The i-gel wasn't really working any better, but what they were seeing was they were able to ventilate the patient very, very well just with a BVM using these techniques. So they said hell with anything and just BLS to this airway for, and this is a long code. Or not a code, the patient didn't go into cardiac arrest, a long call. So this is just a subset of it around the intubations. But they managed the patient's airway. I don't know that we can really call this BLS because they used ketamine and they did a lot of stuff on this airway, but the saturation stayed up. So here's where we were. The patient was initially around 90-something%. They got him up to 100%, and this is where they intubated. The SAT started dropping. They aborted their intubation attempt at 91%, ventilated him back up, and they stayed there throughout the attempt. So despite 2 attempts and an i-gel, they weren't unable to get either of those tubes in, but they maintained the saturations the whole way around. Where if we were only looking at first pass success, we would have said that this was a failure. When we're actually looking at the thing that matters more to the patient, what's going on with their pulse oximetry, we see that this was actually a success. So I look at this as a successful, the DSI was successful here, even if we didn't get the patient intubated. Here was the next one. The pulse ox starts off around 95. We have a data dropout here before the intubation. The intubation occurs right in here. And we see right in here the SAT start coming up quickly. That's about the time we did the ketamine, and we were able to ventilate the patient better or assist the patient with their own ventilation. So the saturations climbed up very quickly. We kept them up. Then we did the intubation. The lowest SAT was 91%, so they never desatted during this time. Here we have, for whatever reason, we have a huge dropout, two really big dropouts on heart rate, and we have a dropout on our pulse ox. This was done before the intubation or before the DSI. This is where we gave the medicine, the ketamine for DSI, and we see a rapid uptake in the pulse ox, and then it remained that way throughout. This little blurb right here was the intubation. SATs never dropped below 97%, despite the fact that they were around 70s before we started intervening with them. So they were in respiratory distress up in here, and then I just happen to remember reading the chart. They failed right in here. All right, respiratory. This was a DSI for a respiratory failure patient. SATs were in the mid-70s. We get them up, and again, this is where we had our ketamine. The SATs went up. We do have a small desaturation. Actually, it's not small. It's a pretty substantial desaturation, and unfortunately, it's occurring right during the DSI. So it is possible that we had a desat in here. I think that is less likely considering how straight the line is here and how straight the line is here, but it is possible. But I think overall that the process worked here too. Here we see the patient again went into respiratory failure. Their SATs started declining here, and then we gave the ketamine. The pulse ox went up very rapidly, remained up at 100% throughout the event. All right, so we have another video coming up that really walks you through the process, but I just want to give you a quick overview of this. So step by step in this process, we start off with our patient with respiratory failure or respiratory distress or whatever the issue is. We have a non-rebreather at 180 liters per minute, whatever it will get turned up to. And then we have our end-tidal CO2 hooked up so that we're getting end-tidal CO2 going into the intubation. We also have this hooked up to oxygen, so we're doing some nasal oxygen, even though we realize that you don't give nearly as much oxygen through the end-tidal CO2 prongs as you do through a real nasal cannula. So we give ketamine, and we're giving ketamine knowing that it is going to allow the patient to continue spontaneously breathing, but provide an amount of anxiolysis that allows us to manage their airway in a more aggressive fashion. Once they go to sleep, we take the end-tidal CO2 cannula off, replace it with a regular nasal cannula that we then crank up to whatever on is, so 15, 16, 18 liters, whatever it's going at. We attach a mask and we put in, you can kind of see the green airway in there, put in a nasal pharyngeal or two nasal pharyngeals or two nasal pharyngeals and an oral pharyngeal, whatever you have to make sure that you're able to get a good seal and get good chest rise and fall. And then this is called the Tower of Power that we blatantly stole from Dave Wirtz and the folks at PHI, who also have been very helpful to us with this process. They've been using this for a while and it's working very well. This is called an HME circuit or filter. Really, HME stands for heat moisture exchanger, but what we are using it for is to keep puke and secretions out of our end-tidal CO2. And I think all of us have seen how many of those end-tidal CO2 probes we go through on a patient because we're sucking blood or mucus or snot or vomit up into the CO2 probe. So this device is designed just solely to save this device and allow us to have continual readings. This is our smart BVM, along with our, right up here is a little flashing light that tells us how often to bag, and this is a PEEP. So the keys to getting the SATs up, number one is down here, use a two-handed seal. Use a two-handed seal with both of your thumbs facing down. So just avoid the C-clamps. Use a two-handed seal. And what is hard to show in this mannequin is use your fingers along the edge of the mandible to pull up. So the way we're opening this airway up is by elevating the jaw. Your thumbs here are just holding the seal down. So a two-handed seal is your number one approach to increasing the pulse oximetry. Number two is use 100% oxygen. Now, I don't think that's really going to be a challenge because we know to use that. So maximize your FiO2, get it up to 100%. And this is number three, is your PEEP valve. So probably the most underused device on our apparatus right now is this PEEP valve. And PEEP is really the key to increasing alveolar recruitment and increasing the surface area involved in oxygenating the patient. You are going to find that if you are making a good seal, and by the way you can tell you're making a good seal is look at your waveform capnography and see that you're getting a good waveform. If you're not getting air in and out of the chest with good ventilations, you're not going to have a good waveform. So use the waveform to make sure you're getting good rise and fall. And again, that's the reason we have to have that end-tidal CO2 on. Then, if you're still not getting the SATs up and they're on 100% oxygen, then start increasing the PEEP. And I don't care how high you take the PEEP. Turn it all the way on if you need to. But keep increasing it until the SATs come up. All right. And then, once we do that, we get the SATs up to above 93%, so 94 or higher. And then we hold that for 3 minutes. and then we go ahead and intubate. And we intubate just like normal. We do continuous suctioning. We use apneic oxygenation. We use the King Vision, holding it low and light, and pass the tube with continuous suction. And then all you have to do is take the mask off, and you're ready to go with end-tidal CO2 attached to your device on the first breath. So that is the approach to ventilation. That's our approach to DSI. Are the references, because I know how much you're interested in references. But now we're going to show you some specifics on the process itself. The things that I want to reiterate is, number one, does not apply in cardiac arrest. Number two, we're not doing RSI anymore. We're doing DSI. Number three, there is nothing about this process that is optional. This is mandatory. It's mandatory that you follow this process exactly as it's defined, and that you use the checklist. So use the checklist, use the checklist, use the checklist. It is mandatory. I want you to follow through every step of it so that we can really avoid this adrenaline surged forgetfulness, because it happens to all of us. It's human nature. The only way to overcome that is to use some adjunct like a checklist. Apneic oxygenation is also not optional. You will do apneic oxygenation, you will do delayed sequence intubation for your patients that need drugs, and you will absolutely keep the sats up above 93% for 3 minutes before you push the paralytic and intubate. What do you do if you can't get the sats up above 93? Then you don't intubate. All right. Well, thank you all very much. And now Archer and company, along with the folks from Round Rock Fire Department, are going to show us how to do this process. Thank you all very much for listening.